So we are back after the break, and once again welcome you all in this third session on pediatric oncology. And the first talk is by Dr. Mary Taj. Dr. Mary Taj is a consultant oncologist at the Royal Marsden Hospital in UK, and her special interests include leukemia, lymphoma, and late effects of cancer treatment. She is also chair of the UK CCLG Pediatric Non-Hodgkin Lymphoma Group, a member of the European NHL Group. She is also the current chair of the CCLG Children Cancer and Leukemia Group, Paediatric Oncology in developing countries. So I invite Dr. Mary for a talk on role of immunotherapy in pediatric Hodgkin disease.
Thank you very much for inviting me. It's always a pleasure to come to Shaukat Khanum and see how much has changed over the previous year, meet old friends again and new people who've joined Shaukat Khanum since I was last year. So thank you again. And my topic is the role of targeted therapies in pediatric Hodgkin's lymphoma. Pediatric Hodgkin's, as you know, is a success story of children's cancer. And the goal in Hodgkin's lymphoma is to cure patients with minimal side effects because chemotherapy, radiotherapy, now targeted therapies all work in Hodgkin's lymphoma. And the goal is to find the balance between treatments and cures so that there are minimal side effects. So this is part of that journey. So my next slide, I'm really going to be focusing on targeted therapies, but I wanted to lay the groundwork for what the standard treatment for Hodgkin's lymphoma is, so that people are aware of what basic treatment patients have before they go on to targeted therapies. Although in some cases, targeted therapies are being used upfront. So this is the Ann Arbor classification for Hodgkin's lymphoma, which is very old and is still being used, from stage 1 being single lymph node region and stage 4 being diffuse involvement of one or more extra lymphatic sites, with stage 2 disease on both sides of the diaphragm. The stage 2 being 2 or more regions on one side of the diaphragm, and stage 3 being lymph node regions on both sides of the diaphragm. In addition, as you're all aware, these symptoms have a slightly worse prognosis, so that too comes into the Ann Arbor classification, and these symptoms are fever, night sweats, or weight loss. So we in the UK use the Euronet, which is the German protocol, which was produced after a big international trial that UK was part of. And on that basis, patients are divided into 3 groups. Treatment group 1, which has stage 1A and B and 2A disease. Stage 2, which is 2B, AE, 2, 1A and 1E, and stage 3 being the higher stages. This is the induction treatment that we use, and I know many of you have either used it or because of its toxicity are no longer using it. But it stands for prednisolone, which is given for 2 weeks, vincristine on day 1, 8, and 15, doxorubicin on day 1 and day 15, doxorubicin for 5 days. And this is an outpatient-based treatment, which in general is well tolerated. Then COPDAC is this the treatment that we use as consolidation. Prednisolone for 2 weeks, dacarbazine for 3 days, vincristine on day 1 and 8, and cyclophosphamide on day 1 and 8. So the treatment protocol itself is based on 2 courses of OEPA. So after staging, which is PET-CT based, they get 2 courses of OEPA and then get a restaging PET-CT. If the restaging PET-CT is negative and shows complete metabolic response, they do not get involved field radiotherapy at the end of treatment. If the PET is positive, then they get involved field radiotherapy at the end of chemotherapy. This one is the treatment for treatment stage 2, where they get 2 courses of COPDAC after the 2 courses of induction chemotherapy. And again, if the PET is negative, they don't get involved in radiotherapy. If the PET is positive, they get involved in radiotherapy. So this is for treatment group 3, where they get 4 courses of COPDAC, and the same, if they are PET positive, they get involved in radiotherapy as well. So this was the standard protocol that we were using up till now, but now for group 2 disease, they, in addition, for treatment group 1 disease, in addition, they get another course of COPDAC. And also, we are using DCOPDAC for treatment group 2s and 3s, but I don't think I need to go into the details of that because my talk is about targeted therapies. But I just wanted to clarify that there has been a change on the protocol we use, which I can go into later if people are interested. But this is the backbone. So OIPA as induction, followed by COPDAC, and then if the restaging PET-CT is positive, you get involved in radiotherapy at the end. So this protocol has excellent survival data. You can see the overall survival and event-free survival for these patients is close to 96, 98. The overall survival is close to 96, 98%. Yes. No, I think I have gone back. And this is the comparison for the different treatment groups. And you can see that even patients in treatment group 3 have a very good prognosis, which is a bit less than treatment group 1 and 2, but still very good. The event-free survival is 86% for treatment group 3. So now coming to targeted therapies and how we're using targeted therapies at an earlier stage. So at the time of relapse, we have 3 groups of patients. The first group is primary progression, which occurs within 3 months after the end of treatment. Early relapse is when it occurs between 3 to 12 months after end of treatment, and late relapses if it occurs greater than 12 months after treatment. And the treatment at this point is then tailored according to these risk groups. So low risk group is the one that has relapse. It consists of groups of patients who have relapsed greater than 12 months after the treatment. And these patients can be treated with standard chemotherapy plus radiotherapy and don't need an autologous transplant. And again, the criteria for which group of patients fit into this group is quite strict, and I'll go into that into the details of that. But these patients don't even need a transplant. Then patients who fall into the standard groups, standard risk group, and this is the intermediate risk group, they get chemotherapy plus autologous stem cell transplant, and some patients who have had difficulty getting into remission, they've needed multiple courses of standard chemotherapy to go into remission, may be given post-transplant radiotherapy or maintenance brentuximab. And then it's the high-risk group where traditionally we have used novel therapies for allogeneic stem cell transplant. So this is the protocol that we have been using. And then I've analyzed 22 patients that we have used targeted therapies in the previous 10 years, which will further define how targeted therapies are being used more and more. So this is the treatment, the low risk group, and they are early relapse, sort of within 3 to 12 months. And their original group was treatment level 1 or 2, or late relapse after including treatment level 3 group. And this group of patients should not have had prior radiotherapy or relapse only outside the prior radiotherapy field, and stages 1 to 3 at relapse. Stages 4 are not considered low risk, and they should not need excessive radiotherapy in salvage. So these group of patients are standard for this treatment is IGEV, and there are many other chemotherapy protocols that you could use instead of that. And this consists of vinorelbine, ifosfamide, gemcitabine, and prednisolone. So after 2 courses of IGEV, they get an early response assessment PET. And if there is adequate response, then they get 2 further courses of IGEVs and involved field radiotherapy. Coming to standard risk, these group of patients have had any primary progression or early relapse after treatment level 3, and they've had prior radiotherapy, or they are stage 4 at relapse, or they need excessive radiotherapy in salvage. And they also have if they've had inadequate response after the early PET response in low risk group. So this group of patients again are given 2 IGEVs, have an early response PET, and if there's an inadequate response, they get 2 courses of bendamustine and brentuximab. So targeted therapy at this stage. Then if they have an adequate response, they get 1 to 2 courses, further courses of bendamustine and linca and brentuximab, and then they're going to have an autologous stem cell transplant. If in this group of patients, they get adequate response after PET-CT, then they get just 1 to 2 more courses of IGEV and autologous stem cell transplant. So for standard risk patients, all patients need autologous stem cell transplant. Then for high-risk patients, which is quite a difficult group to treat sometimes, these patients can start with 2 courses of IGEV. If there's inadequate response, they get bendamustine and brentuximab. And if there's inadequate response, they get autologous stem cell transplant with maintenance brentuximab or radiotherapy. And if they've needed multiple courses of treatment to get to PET negativity, then they fall into a very high risk group in which radiotherapy or targeted therapies are often used. So the targeted therapies that we have for Hodgkin's disease is the anti-CD30 antibody brentuximab, which is an antibody drug conjugate, or there are the checkpoint inhibitors, nivolumab and pembrolizumab, and combination therapies with chemotherapy drugs are also used. And often these targeted therapies are used as a bridge to transplant or to radiotherapy. The checkpoint inhibitors are PD-L1 and PD-1 inhibitors, and they inhibit the they promote the binding of T cells to kill tumor cells. So these checkpoint inhibitors are also being used more and more in Hodgkin's lymphoma. And then brentuximab is a anti-CD30 drug conjugate that kills the Hodgkin cells by binding onto CD30 positive cells. So this combination of brentuximab that has had now many publications both in adults and children, and it is associated with about a 75% response rate in patients with relapsed Hodgkin's disease. This combination of brentuximab and bendamustine had a CR, in a phase 2 study, had a CR rate of 82% and overall response rate of 94%. So as you can imagine, these patients do really well. Then nivolumab, which is a monoclonal PD-1 blocking antibody, which potentiates anti-tumor T cell activity. Overall response rate in this particular trial was 87%, with 17% showing complete response and 70% showing partial response. So in order to kind of look at this in greater depth, I looked at patients who were less than 18 years old who had been diagnosed at the Marsden in the last 10 years. And of these, and patients who'd been treated with targeted therapies. So there was a total of 22 patients treated, 21 patients survived, and there was one death. And originally, brentuximab, either alone or in combination, was used in second or subsequent relapse. Now, targeted therapies are used in first relapse, and adults are also using chemotherapy plus brentuximab as first-line therapy. And again, this is to reduce the toxicity that is seen in patients, as we were discussing this morning about blinatumomab. And this is also used as salvage therapy in multiply relapsed patients following radiotherapy or transplant. So this first group of patients where it was used as a bridge to transplant and radiotherapy, the first patient relapsed post autologous transplant was given 6 courses of brentuximab, had allo transplant, and then radiotherapy, and that patient is fine. The second patient who had post auto relapse, given brentuximab, 3 courses plus radiotherapy. And in all these cases, they all had PET scans and were only taken to the next step, transplant or radiotherapy, if they were PET negative. There is data to show that if they're still PET positive, then the results are not quite so good. So this next one had progression, was given IEP, which we were using in those days, IEP, ABVD, brentuximab into 4 courses, then autologous, and then progression, brentuximab, bendamustine, and then autologous. So you can see the pattern that chemotherapy was still used as first line or a second line after relapse, but then they went on to use, we went on to use brentuximab, which was the drug in those days. Initially brentuximab, and in this particular patient, brentuximab and bendamustine, autologous transplant radiotherapy, and again, so on and so forth. So all of these patients did quite well with brentuximab, either alone or in combination, and then had to be consolidated with autologous stem cell transplant or radiotherapy or both. And then we had this one patient who had originally been treated with ABVD into 6 courses, was in remission for 10 years, relapsed, was treated by our adult teams who gave this different protocol, GDP, then they showed insufficient response, had 6 courses of pembrolizumab, relapsed, then brentuximab, autologous transplant, and then had brentuximab after transplant as well. And brentuximab, GEMP into 3 radiotherapy and autologous stem cell transplant. So you can see that there is no standard way of using it, but it is being used much earlier. These targeted therapies are now being used earlier because up till now, what we believe is that they are less toxic as compared to standard chemotherapy, particularly in the relapse setting where the patients have already had prior treatment. And often these patients are teenagers and don't want chemotherapy. And if they know that something is available, they are asking for it more and more at the time of first relapse. So checkpoint inhibitors in particular are being used as first line at relapse. We have, I mean, the Marsden has open studies where we can get these drugs free even when they're not in the open market, but it's important to know if they are effective, and certainly long-term follow-up is required to look at the particular side effects. The side effects we've seen in one patient who had treated with pembrolizumab at first relapse was thyroid. She had hypothyroidism, and she still has it even after transplant. And then another patient developed diabetes, type 1 diabetes, which was a brain tumor patient given for totally different reasons. But I'm just saying that these agents are not without side effects, but in some ways, when the side effects are different, then you can't just say that they are less, but especially in the short term, they are much less as compared to chemotherapy. And then we, even after treating so many patients, the number of patients we've seen these side effects are not very high. So this next patient had IGF, which was our standard treatment, then bendamustine and brentuximab and bendamustine into 6, then insufficient response, then pembro 5 courses, and then had an autologous stem cell transplant. So we continue to give different treatments until they become PET negative, and then they're long, because we know that their long-term prognosis will be good if we can get them PET negative. So the next one was part of a trial, had nivolumab and brentuximab, insufficient response, then brentuximab and bendamustine, and then had radiotherapy. The third patient was a high-risk one with progression, pembro into 4, brentuximab and bendamustine and autologous stem cell transplant. So I just wanted you to know that there are multiple lines of treatment that you can give them. And the next one, this particular patient of mine just refused chemotherapy because she knew about the pembro trial, went on to trial, was given about 5 courses, did not respond. Well, insufficient response. She had a partial response. Then brentuximab and bendamustine and autologous transplant, and so on and so forth. Then this group of patients were treated by my adult colleagues, and they have a protocol called AVD and brentuximab. I don't know how expensive brentuximab is. It's probably cheaper than it used to be. Very expensive. It is. It's very expensive. 60, 70 rupees.
Whatever each file is like about 4-5 lakhs.
The patient will spend about 60,000 rupees. Well, it's not worth it then, because there are treatments that work without brentuximab. But the reason why the adults have started is they have a protocol in which brentuximab is given at day 1 and day 15, I think, in each course. And they use AVD because bleomycin can have lung toxicity. So that's why they gave up bleomycin. And so they've treated, in the pediatric age range, they've treated 4 patients. I'm sure they've treated many more in the adult, in patients older than 18 years old. And all these patients, from what I could see from their notes, they were doing well and in CR. But this is just to explain how different patients, how targeted therapies are being used earlier and earlier as compared to when I started treating the Hodgkin's. So this is the other way that it is used, and in this case, it's a necessity. These are those patients who just continue to relapse with multiple different courses of chemotherapy. And I think the first patient had had about 3 courses of chemotherapy, then went on to have brentuximab and bendamustine, had an autologous transplant, relapsed after that. We gave her nivolumab and a modified OINCA because she had a lot of anthracyclines, had radiotherapy, and then a haplo stem cell transplant. And she's a survivor, but she's got lots of side effects. She can renal failure, is going to need a renal transplant in the future. So, but at least she's alive. So multiple courses of different treatment. Then the next one, and this is the patient who died, had 2 courses of IGEV, had bendamustine and bendamustine into 3, then had 6 courses of nivolumab, had radiotherapy, autologous stem cell transplant, then relapsed, had allo, relapsed after that, and unfortunately died. Last patient, IGEV into 2, ABVD into 2, autologous stem cell transplant, brentuximab and bendamustine, allo transplant, relapse post-allo, again given brentuximab and radiotherapy. So again, these therapies, even if patients relapse after, you can use them again. And it's not that they're not going to be effective. You know, with chemotherapy, we say they've had this drug and they've relapsed, then we can't use it again. But with targeted therapies, we seem to be able to reuse them and they can still be effective. So for multiply relapsed patients, I think it's worth going for targeted therapies if you can afford it. I'm not minimizing the cost and how difficult it is to get hold of these drugs. So in conclusion, my conclusion with Hodgkin's is don't give up too soon. Hodgkin's disease at relapse and even multiple relapse is highly curable. For the good risk group, you don't even need stem cell transplant. Those patients who relapse late and haven't had radiotherapy, don't have stage 4 disease at relapse, they can be treated with just chemotherapy and radiotherapy alone. And the need for transplant is determined by previous treatment, timing to relapse, and chemosensitivity. So basically, there are many different protocols you can use at relapse. But if the patient doesn't respond to the relapse treatment, then the overall prognosis is not that good. And that's the group you would want to give brentuximab and bendamustine to. Then make sure the patient is in PET negativity and becomes PET negative before you go for autologous transplant. Allo transplant should be reserved for resistant disease or post-auto relapses. And for us, we use beam chemotherapy as conditioning, although CBE is also used by many centers. So I think the original time I had was 20 minutes, so I may be a bit early. Now I know I have 30 minutes, so I think I finished a bit early, but thank you. Thank you, Rosie.
Thank you very much, Dr. Meritaj, for such an elaborative talk, like always. And our next speaker is Dr. Zahra Fadoo, and she's chair of Department of Oncology at Aga Khan University Hospital since 2019, and she has been working as professor of pediatric oncology since 2017. She has special interest in pediatric leukemia, lymphoma, and supportive care. And she has over 50 publications. So over to you, Dr. Zahra. Thank you.
Assalamu alaikum, everybody. And thank you to the Shaukat Khanum Conference Scientific Committee and to Shaukat Khanum Conference leadership for inviting me and giving me this opportunity to talk. Rabia called me for what's the topic, and suddenly I get this, my topic is acute complications in allergenic hematopoietic stem cell transplant. And I said, oh, now what am I going to say for this? Where do I start and where do I end? He said, Jo aapki marzi hai, bol de. तो आज मैं अपनी मर्जी से again I'm going to restrict the talk. It's going to be non-infectious complications because otherwise, you know, it's going to be a huge it's a huge topic. I think you can have like a 2-day conference on it. So restricted, and I'm just going to mention some of the things, and I hope you know, whatever the, because of the time constraints, it should be interesting. So to start with, I think the, you know, the transplant, talking about transplant in a pediatric oncology setting in an LMIC, people keep asking, you know, okay, is this worth it? Is this relevant? And just to, and I think Shaukat Khanum has like pointed it out that it is very relevant and it is very needed for our children. So if you, so for that, I just wanted to start with the history of transplants in Pakistan. We already, the first bone marrow transplant was done in 1957, and Don Thompson, we all saw the picture. He actually got a Nobel Prize for that. Somewhere between 57 to 65 years, started with a stem cell infusion and then went to a synergistic transplant with an identical twin. For the first case in leukemia. So that was like ages ago. But for Pakistan, we started transplants in about a decade ago. So it's not been that long. It started with just 1 or 2 centers. It started with an autologous transplant. And in the last decade, we have about there are 12 facilities right now and institutes that are performing autologous as well as allogenic transplant for children as well as for adults. But unfortunately, this is only in Punjab and Sindh. So there are 2 provinces which have absolutely no facility for that. In last 2 years ago, or almost 4 years ago, there was a Pakistan bone marrow transplant consortium that has been made. And I think that is excellent in coordinating the care, because again, every center is doing a few of them, and to get that experience and to put it into research and take ahead, it's very essential that all of us get together. This was a publication last year from this group. And if you see the transplants, they actually numbered the transplant for the last 2 years, which was 21 and 22. And about in the last 2 years, about 800 plus transplants were done. There was a dip in 22, but that was, I think, COVID related. But yes, on average, about 500 transplants are being done in Pakistan right now. And if you see the type of transplants, the haploidentical transplants in the last few years has been increasing. So again, as we go ahead, expertise develops and institutes come up. Pakistan is now starting to become, you know, institutes are starting to do the transplants. The reason why the transplant is being done, and again, that's totally different from what you look at the international CBMIT guidelines, which mostly are because of leukemias and mostly amyloid leukemias. But if you see here, the majority are thalassemia and aplastic anemia. So, you know, our disease spectrum is totally different. Our needs are different. So our transplant related complications and, you know, further is all different for us. So with this group in BAT, I think we are all coming up with guidelines, with national surveillance, with researches all together. We'll keep having more information. So that is what is happening in Pakistan. Just to for nomenclature, the stem cell transplant is classified by donor as autologous. So from self, syngeneic from a twin, and allogenic from anybody, and either it may be an identical sibling, either relative may be parents, and unrelated. So these are all allogenic. For conditioning regimen, you may have a non-amyloablative. That means that you do not ablate the bone marrow totally. You may have a reduced intensity, and then there's a myeloablative regimen, especially, you know, again, depending on the condition that you are doing it for, these 3 can be used accordingly. The graft source, so where the stem cell is coming from, umbilical blood cord is one option, which again is not available for us, but peripheral blood and bone marrow is what we are doing here. Umbilical cord, I think in the last few years has been less used ever since haploidentical transplants have been coming up. So let's see what the use of that is going to remain in the next few years. Graft manipulation is whatever source that you're taking it out from. How are you manipulating it? Is it an in vivo kind of selection, ex vivo, or negative positive selection, depending on the chemotherapy used, as well as what kind of agents that you used. So either you're manipulating it within when you are infusing it in the body by giving POSI, that's in vivo, whether you're doing it ex vivo. So, you take the stem cells and you deplete the T cells. So, you're depleting it outside. So this is some of the definitions of that. So the risk factors for complications are it starts with the indications, of course, multiple relapsed ALL and AML versus a thalassemia, so versus a primary immune deficiency, all have their different niches and, of course, complications there. Type of donor, HLA typing, which is very important because the more mismatch you have and where the mismatches is depending on that. Source of graft that we talked about, conditioning regimen, stem cell source, and CMV status. So one important thing is the CMV of the donor as well as the recipient, and donor age and sex. This is a chart which tells you about the stem cell product. Okay, so between peripheral blood cells, bone marrow, cord blood, and like I said, in vivo, if you T cell depleted bone marrow, which may be in vivo or ex vivo, and haploidentical T cell depleted, which we usually do the post-transplant cyclophosphamide. And if you see, basically the complications are all related to your graft and especially to the T cells. So depending on how much T cells that you have, what are the CD34 that you can get from these sources, time to neutrophil recovery, because the earlier you recover, the less infections you have, the delayed it is, more infections. Early post lymphoproliferative disorder, again, depending on what the source is. Basically, it comes all around to the T cells that you have in the graft that you're infusing. Time to immune reconstitution, again, if you look at the cord, it's much delayed. If you look at the peripheral, it's much earlier. Risk of acute GVHD, again, for the T cell depleted, it's very low. For haplo, it's low because, again, they're using post-transplant Psi. But if you see for peripherals, it's a higher. And risk of chronic GVHD actually is higher for the peripheral because your active T cells are still present in your peripheral blood. Through the journey of your transplant, it starts with, when you start conditioning, which may be day -11, -20, or 19, or 7. Wherever you start with your chemotherapeutic agents. Nausea, vomiting is one of the main thing that happens with this high-dose chemotherapy. Mucositis, and of course, pain is there. Then comes your day 0, where there's infusion of your stem cells. And then the risk of infections increases in the first 14 days because that's your neutropenic phase. And then once at day +14 and beyond is when your engraftment starts, where that's when your engraftment syndrome, GVHD, start playing into account. Infections, of course, are all the way. And somewhere along these lines is also a chance of veno-occlusive disease, microangiopathy, and PRES, which is all related to the medications that you're using for transplant. Very famous diagram. I think everybody kind of who's gone through the reading goes through this, because this is the immune reconstitution which happens after transplant. So again, the first few days, neutropenia is the basic problems, and that's why the infections that you get is mostly bacterial. As you compared, as you go, lymphopenia, hypoglobulinemia persist, and if you go along, then the infections kind of change from fungal to viral to CMV reactivation, and the transplant associated factors, again, the first few weeks is mucositis, because that's when your neutropenia is there. VOD, central line infection, thrombocytopenia, and related to that, idiopathic pneumonias and bronchial hemorrhage can occur, and then from acute GVHD to chronic GVHD. So I'll just go through 3 cases I have, and these are real life cases that we've had going through the last few years that we are doing transplant. And this is a 7-year-old boy who had transfusion-dependent thalassemia, admitted for transplant with his matched sibling donor. Conditioning was ATG, BU, flu, and PSI, and he develops right-side abdominal pain, fluid retention, icterus, and refractory thrombocytopenia. Answers. Everybody awake? Post-lunch. What's the most likely? Lots of things need to be ruled out, but yes, you guys are awake. Yes. So again, I think the point over here, this is the EBMT diagnostic criteria for VOD is now reclassified as sinusoidal obstruction syndrome. And again, there's no limitation and the presence of 2 or more. So unexplained consumptive transfusion refractory thrombocytopenia is one very important characteristics, and unexplained weight gain, and a weight of more than 5%, hepatomegaly, ascites, and rising bilirubin. And again, it's a little bit different from adults. Pediatrics can have very vague symptoms, so it's suspicion should be extremely high when you are treating patients, and especially then. So this happens in about 15 to 40% of transplants. And again, especially with myeloablative conditioning. The grade again may be mild, so not everybody has to go through the florid, but it can be severe enough to go into a multi-organ failure. So the risk factors actually for our child also was the use of busulfan and liver dysfunction, which usually thalassemics have because of their iron overload that they have. Total body radiation, serious infections, and concurrent GVHD are also related to have an increased risk of developing sinusoidal obstruction syndrome. The pathophysiology again is related to the chemotherapy and so conditioning basically, whether it's chemo, whether it's radiation. And what happens is there's activation of vascular endothelial cells, which release your heparinase. There's a lot of breakdown of cells. And once these breakdown of cells, there's a release of your von Willebrand antigen and platelet aggregation. So that's why the platelets get consumed. So there's prothrombin. So a lot of, and that's why the microclots are formed within the sinusoids, and that's how they get obstructed. So this is from 2017, but this is almost the same, the guidelines that was a consensus report from the report from pediatric lung and sepsis investigators for veno-occlusive disease. And some of the questions that the recommendation covered, one of the first questions, what was the standard laboratory investigations? And we all struggle to see, okay, what's the best way of diagnosing SOS. So again, the most important thing is that it should be it's a clinical diagnosis. So if you suspect it, you should manage accordingly. You have to have very, very frequent monitoring of LFTs and CBC and chemistries. Ultrasound is helpful, but if it picks up, it's good. If it's negative, doesn't mean that that's not there. Liver biopsy is not recommended for a diagnosis. The other question, what are the recommendations for prophylaxis for SOS? And I think a lot of studies are still going on. URSO, which is ursodeoxycholic acid, is one of the factors that has documented several studies that this does help prevent it. Defibratize is something which is still in investigation. It has proven to be very effective, but as prophylaxis, does it work? Does it not work? The question is still out there, and it's not the standard right now. But the most important thing is that as soon as the children start getting into the +12 plus thing, the most important thing is fluid overload and restriction and diuresis. So this is, you have to be on top of your fluids at this time. The other questions, what is the treatment? So for treatment, that is definitely defibrotide is indicated. and it does prevent multi-organ failure and it's supposed to continue on at least for 3 weeks or till resolution of your symptoms. Steroids has also been used, but with a variable response. Well, if you don't have any choice, especially, deflupredise is not available for us and not easily available, maybe sometimes that's what we use. Coming to a second case, this is our 13-year-old boy with congenital dyserythropoietic anemia who underwent a fully matched transplant from sister, and on day 13, he started developing fevers, but with mild respiratory distress and oxygen requirement. Yes, is here? Yes. So this is the engraftment syndrome. Again, the pathophysiology is not very much fully understood, but it is said that it is at the time when the neutrophils start coming back, and at that time is a lot of cytokine and cytokine release syndrome, and so this is what they call the engraftment syndrome. Again, it has criteria. And I think major is one thing you have to rule out for any fevers in these children is infections. So it has to be a non-infectious fever, skin rashes, and pulmonary edema. So something differentiating from, they all happen at the same time. But pulmonary edema over here is more common as compared to any other. And again, the same thing, they can have weight gain, they can have hepatic renal dysfunction, and they may also have transient encephalopathy. This article was a review, and they went through all the symptoms, and see in a majority of them, fever, skin rash, weight gain was the majority symptoms in all. A quarter got pulmonary edema, infiltrates, deranged LFTs, and so these can be all presentation of engraftment syndrome. Again, the pathophysiology is all starting with your conditioning regimen where high-dose chemotherapy radiation is used, which causes endothelial damage. The endothelial damage then releases your tumor necrosis factors, IL, interleukin, and there's a cytokine storm. This causes the capillary leak, and that's why you get the symptoms. The management is that, if you're suspecting engraftment syndrome, then you have to, the first thing you do is rule out infections and any drug rash, any diarrhea associated with anything, fluid overload. You give them supportive care. If they resolve the persistent symptoms, then the methylpred works beautifully with them. You can start with a lower dose and not responding on a higher dose, and usually tapered over 7 to 10 days, and they usually have a complete resolution. Third case, this 13-year-old girl with myelodysplastic syndrome who's actually right now admitted undergoes haploidentical transplant with post-transplant PSI. She engrafts on day 17, but then develops loss of appetite, nausea, and then severe diarrhea with crampy abdominal pain on day 24. Yes, even Rabia knows. So this is acute GVHD. Again, acute GVHD is immunological activation of donor lymphocytes targeting major or minor HLA disparity in the tissue of recipients. So basically, the basic function is that all the donor T cells that were gone is now acting towards the recipient HLA disparity, and they attack the organ systems in the body. And characteristically, the 3 organ systems that they attack is your skin, your liver, and your gut. And if you look at the risk factors of GVHD, the donor, again, it's the HLA incompatibility, unrelated females donors, and older age donors. They have a higher risk of, they will, if the graft taken from there, higher chance of GVHD. From the recipient, if it's older, stem cell source, again, peripheral blood is supposed to be more than bone marrow, than cord, and a T cell replete graft rather than a T cell deplete graft. Transplantation protocol, myeloablative, higher chance of getting GVHD. And the clinical course is, again, If you have more infections, you have more complications, they will end up having more GVHD. Again, the pathophysiology for GVHD is like a threefold. There's an initiation phase, there's an activation phase, and then there's affective phase. So anyways, the thought again behind it is conditioning regimen, which causes tissue damage. The tissue damage release a lot of cytokines, and activation presenting cells. These then then go on to develop the T cells are now become activated. The activated T cells now go and attack the cells of your body, which is mostly the liver, skin, and your gut. There's two ways of the staging and grading, and again, it's cumbersome, but it is important to document because that's how you kind of quantify them and document them. So there's a stage, and I'm not going to go through all tables, but from 0 to 4, it's depending on the intensity. For our child, when any bloody crampy abdominal pain and bloody diarrhea is stage 4. So that's kind of severe GVHD. Then comes the grading. So grading again depends on the amount of symptoms and what was the stage at that point. The important thing, just to let I think that was important difference that has happened in the last few years is reclassification terminology of graft versus host disease. And so the initial part was that anything beyond day plus 100 would be chronic, which is not the case anymore. It is the symptoms. So anything with the liver, gut, GI will remain acute GVHD. Acute GVHD happens before day 100 is classic. If it happens, the same symptoms happen after day plus 100, will be still acute GVHD, but maybe late onset, maybe recurrent, maybe persistent. So again, the terminology is now different. The chronic GVHD has a specific symptom presentations. So, with skin, like leukopenia or mouth, different, hardened mouth, lichen planus, eyes, esophagus, so, strictures in the esophagus. So the symptomology or chronic GVHD is totally different than acute GVHD. And of course, there's always an overlap between one. So acute can progress into chronic, acute and chronic can coexist. But again, these are very important nomenclatures because again, the treatment is different and prognosis is different. So this is something that we need to keep in mind. Management starts from prevention. So again, the most important thing is T cell manipulation. So match sibling, you usually use calcineurin and methotrexate as prophylaxis. For match unrelated, you keep adding on to immune suppressions, which may be to your calcineurin inhibitor, to methotrexate, you add either post-transplant Psi, ATG, elotuzumab. They're all T cell suppressants. Mismatch, again, you add more. And haploidentical, what has really worked is your post-transplant Psi. But together with that, there's always also very great, excellent results coming up with in vivo T cell depletion with T cell receptor alpha beta CD19 depletion. So how do you manage acute GVHD? Acute GVHD does happen. It is steroids. There's nothing else. So anyway, so very important to remember that grade 1 skin can be just managed with local. But once it goes to grade 2 or beyond, then methylpred can be started lower, but usually 2 mg per kg. And then it keeps getting reevaluated after 4 to 7 days. And either you taper it or you continue. And then you can label it whether it's resistant or whether it's responsive. So again, nomenclature, steroid refractoriness is when there's acute GVHD which progresses on full dose of methylpred 5 days after the methylpred has been started, or failure to improve within 5 to 7 days of treatment. Incomplete response after 28 days will be labeled as steroid refractoriness. Steroid dependence is that inability to taper prednisone or recurrence of once the steroid has been tapered. And intolerance is that when you give steroids and for some reason the patient cannot tolerate it. So for steroid refractory GVHD is a huge challenge. It's a poor prognosis. One thing that has been established and recently approved is ruxolitinib. So any steroid refractory GVHD should be started on ruxolitinib. And after that, if this doesn't get work, then there's very, very little data as to what exactly is working for these children. So in summary, hematopoietic transplant offers cure to a lot of malignant as well as non-malignant diseases. And with the improvement in your conditioning regimens, your prophylaxis, your conditioning, supportive care, the indications of transplant for benign diseases has been coming up much more. And the acute, but you have to also remember once we have broadened these transplant indications, acute and long-term toxicity remain an important consideration, and they need a lot of support and resources. So thank you so much. That's from me. Should be within time.
Well in time, yeah. Thank you very much, Dr. Zara, for a very comprehensive talk. And our next and the last talk is by Dr. Samina Afzal. Dr. Samina is currently working as a consultant pediatric oncologist at Sheikh Khalifa Medical City in Abu Dhabi, UAE. And she also had adjunct clinical professor post with Mohammed bin Rashid University, which is the most renowned university in UAE. She has been trained and worked at Great Ormond Street Hospital, London, and Hospital for Sick Children, Toronto. So she is going to discuss thrombosis and anticoagulation.
Okay, so in the last, everybody's tired. So we're not going to what is the thrombus, what is the anticoagulation, is everybody knows what is that. Neither we are discussing, we will just go to few cases. It's the ASH-directed cases. So last ASH guideline, American Hospital Society of Hematology came in 2018. Since then, no new guidelines have been come. It was expected to this year that the guideline will come, but it's still in working. So how are the guidelines developed? Each guideline panel was formed by following criteria, balance of expertise and disciplines and all that. We'll just go through that and then we'll get through some cases. At the end of the session, you should be able to describe recommendation for the management of renal vein thrombosis, describe recommendation for management of VTE associated with central venous catheter. That's the most common with our oncology children. Describe recommendation for the management of symptomatic and ASM. Why the guidelines are important? We got a huge, it's routine. We get a lot of calls from ICU. Child is not just oncology children, child is TPN dependent, has a thrombus, and we have booked the child for time for the line removal. What's the next step? So this is very important to decide when the line to be removed and line not to be removed. In what situation you will, line should not be taken as a joke. It's a central line. And it's very important in the children who require it over a long period of the night, not only the oncology children, but in general pediatric as well. Pediatric venous thrombosis is a disease primarily of the sick children. VT in general pediatric population is rare. The rate of the VT in children is increased by 10 to 1,000 times in hospitalized children. The presence of central venous catheter is main precedent for VTE in neonate and other children. So there are no anticoagulation drug approved for use in children with little pediatric specific VTE research. Most are adult, but we use them because whether to treat and what type of the treatment is different in different scenario. So gross hematuria in a neonate, 3.8 kg male infant, born at 39 weeks gestation to 35-year-old mother with a gestational diabetes managed by diet and insulin during pregnancy. On day 1, the child developed gross hematuria and palpable mass in the left mid-abdomen. Leukocytes 25,000, platelet 90,000. Serum creatinine is normal, so the kidneys are working fine. Blood pressure is 85/40, so that's good. Doppler ultrasound, swollen echogenic left kidney with prominent medullary pyramids, absent, so it's an occlusive clot. Absence renal venous flow with occlusive clot visualized in the renal vein extending to the junction with inferior vena cava. Consistent with unilateral left venous thrombosis without extension to the inferior vena cava, but reaching to the junction.
The neonate has developed unilateral renal venous thrombosis without extension to IVC. His platelet is 90,000 and he's hemodynamically stable. What would you suggest? No anticoagulation, repeat ultrasound to ensure no extension, anticoagulation therapy, thrombolytic therapy, or surgical thrombectomy? Huh? Okay. Which one? Okay. Okay. So it's okay. While we're discussing, the panel suggests, this is the guidelines, ASH guideline. The panel suggests using anticoagulation rather than no anticoagulation in neonate with the renal venous thrombosis. 9 observational studies in children, case report and case series, and they recommend anticoagulation considered to have potential benefit when long-term benefit are considered, for example, avoiding hypertension and potential renal damage. So here the cause of treating is not because of the vessels, it is for the late effects of the kidney. Yeah. Anticoagulation likely more important, although with bilateral and progression to IVC. But to avoid hypertension and late effect to the kidney, it's important. Bleeding risk with treatment is likely impacted by severity of disease, age, gestational age, degree of thrombocytopenia, very important, degree of renal dysfunction, involvement of adrenal glands. So your patient with unilateral RVD started on therapeutic anticoagulation with low molecular weight. Within 48 hours, his hematuria resolved and he remains clinically stable with no progression of thrombosis. He continued low molecular weight on discharge with his ultrasound at 12 weeks demonstrate partial recanalization of left renal vein. Left long-term follow of the blood pressure and renal function will be required. Anticoagulation without thrombolysis is recommended as a frontline therapy for all renal venous thrombosis, but especially in neonate and especially in bilateral or extension to IVC. Decision about anticoagulation should be considered both immediate consequences and long-term potential benefit to renal function and avoidance of hypertension. Therapy should consider risks for bleeding, including degree of thrombocytopenia, renal dysfunction. And so the important in this case is that it will be individualized what you are looking. You are not just looking to treat the thrombus, to recanalize the vein, but to prevent the kidneys for future. This is a very interesting case. 10 years old with acute lymphoblastic leukemia. Receiving induction with PEG with asparaginase containing chemotherapy via central venous segment line. Present to oncology unit with 36 hours of right upper arm and forearm swelling and redness. So it's a symptomatic. Line is functioning normally for administration of chemotherapy and regularly flushing. Doppler ultrasound of the right upper extremity is done, non-compressibility at right internal jugular vein. On Doppler flow, the clot extends into the subclavian vein, although the brachiocephalic vein and superior vena cava appear patent. Your patient who is receiving, now we've got receiving asparaginase-based chemotherapy, has an acute central line associated right internal jugular vein DVT. Line is functioning. Important is concentrate. She required additional treatment for induction chemotherapy. In addition to providing anticoagulation therapy, what would you suggest next in her management? Platelet count. Okay. No, among these 4. Provide AT replacement. D, yes. Do not remove central line, do not prove AT replacement. But this is the functioning line. You should not remove it because taking it out and putting may be more damaging to the vessel and will come by not to do AT replacement. Panel suggests no removal. Rather than removal of the functioning CVAD in pediatric patient with symptomatic central venous line related thrombus who continue to require venous access. High value on avoiding insertion of another line in children who may have limited access, and placing another line cause new endothelial damage and may be more thrombogenic. Okay. The panel suggests against using AT replacement in addition to standard anticoagulation rather than use standard anticoagulation in pediatric patient. So ASH panel suggests that continue anticoagulation. Now next what will happen? The subgroups when AT replacement might be justified if the patient is failing to clinically respond to initial anticoagulation. Children with age-appropriate low level of AT, children with ALL on induction chemotherapy using asparaginase, nephrotic syndrome, neonate, liver transplant patient, disseminated intravascular coagulation in VTE, known inherited antithrombin deficiency. Continue. Start your patient on standard anticoagulation with low molecular weight. And despite dose escalation, the anti-XA level remains subtherapeutic. After 7 days, now you concentrate that this one is anti-XA subtherapeutic. After 7 days, there has been worsening in the arm swelling and discomfort. Two things, anti-XA is subtherapeutic and there is a extension of the clot or like a symptomatic mode. Oncology nurse now report that they are having substantial difficulty using the line. These are very routine cases we come through and are unable to flush it. Now the line is not functioning. You repeat a Doppler ultrasound of the right upper extremity. It now demonstrates extension of the DVT with thrombus in internal jugular vein, subclavian vein, brachiocephalic vein, and superior vena. Previously, only. Now there are many things. Your thrombus is extending, and anti-XA level is not getting therapeutic and symptomatic more compared to pre. Your patient is receiving asparaginase-based chemotherapy and the line is not functioning properly now. Should the central line be removed now? Yes, it should be removed. Yes, but removal should be delayed until end of anticoagulation. No, because removal may cause pulmonary embolism. No, because removal may precipitate endothelial injury and person. It is not always necessary to take the line. Okay. Recommendation. Panel recommend removal rather than no removal of functioning or unneeded CVAD because now the line is not functioning. So better to take it out. In pediatric patient with symptomatic line-related thrombus. The panel suggests delayed removal of line until after initiation of anticoagulation rather than immediate removal in pediatric patient. This is very usual. I still see this. We get a call in PICU. There is a thrombus. We have removed the line immediately. And then they call us what to do. Rather than immediate removal in pediatric patient with symptomatic central venous line-related thrombus who no longer require venous access or their CVAD is functioning. So we will remove it if it is non-functioning. And optimal timing of the removal. A few 3 to 5 days of anticoagulation are felt to reduce potential risk of emboli leading to PE or paradoxical stroke, although quality of the evidence is uncertain. So generally we prefer to give anticoagulation for 2 to 3 days before removal of the line if we plan to remove because it's not functioning. Consideration affecting timing, surgeon, operating rule, shunt and all. In this case, the child has already received. It's different now. Child has already received 7 days of therapy. So you don't wait now. You will not say the guidelines say 3 to 4 days. Child has already received. Line is not functioning. So we'll remove the line. We will come to that. Your patient who is receiving PEG asparaginase-based chemotherapy has developed progressive thrombus, we know, despite standard anticoagulation. Line is not functioning. What would you suggest? They have not removed the line. They say, okay, the line should be removed. What should you suggest for management of antithrombic therapy at this point? Continue with current low molecular weight. Switch anticoagulant therapy to intravenous unfractionated heparin. Add empiric AT replacement therapy to current. Measure AT level, and if low, then add AT replacement therapy to current low molecular. ये तो बहुत आसान है. Anti-XA was low, yes. Patient is on the PEG. Line was not functioning, and what? Anti-XA is low. Measure AT level. Yeah, D, agree. Measure AT level, and if low, then add replacement therapy to current. Because there may be many reasons of not getting a therapeutic answer. Children are not getting proper dose. This have been seen even in hospital setting. The dose sometimes is very small. Proper dose is not given by the nurses. So there are many reasons. So we have to measure the AT level. If low, we'll do the replacement. Okay, the panel suggests using AT replacement therapy in addition to standard anticoagulation rather than standard anticoagulation alone in patients who fail to respond clinically to standard anticoagulation, in whom subsequent measurement of AT concentrate revealed low level. Antithrombin replacement would be commenced if there was continuous thrombus growth and or failure of the clinical response despite adequate anticoagulation. However, there is no evidence to suggest improved outcome in these patients with AT replacement because in pediatric studies are very limited. You measure antithrombin activity, determine its low, AT activity is 0.12. You supplement standard low molecular weight anticoagulation with AT concentrate, and within 3 days, there is a symptomatic improvement, finally. The CVET line is removed and a central venous catheter is placed at another venous access site for subsequent chemotherapy treatment. When thrombus occur in association with line, the CVET should only be removed if no longer functioning or if it is in no longer use. AT replacement therapy is not recommended routinely for treatment of pediatric DVTP or central venous catheter. Certain subgroups may benefit from addition of AT replacement to anticoagulation if they fail to respond, only if they fail to respond to anticoagulation and their level is low, including those receiving asparaginase. Another case. 4-year-old female underwent open repair of ventricular septal defect. Intraoperatively, a right internal jugular vein central venous catheter was inserted. Postoperatively, recovering well, central venous catheter was removed immediately postoperatively. This happened to use. They do the cath and then they remove it. 3 days since surgery, she undergo routine echocardiogram to review the PSD closure. Thought that there was something abnormal in the superior vena cava. Ultrasound was done, non-occlusive. So there is a non-occlusive thrombus noted in right internal jugular vein, extending down into the superior vena cava, but not into right atrium. No DVT in remaining veins of upper extremity. You have diagnosed your patient with asymptomatic non-occlusive DVT in internal jugular vein and superior vena cava, which was likely provoked by a central venous catheter that has been removed. What management would you suggest for this patient? Asymptomatic DVT. Anything, because that's very good, because there is no right and wrong in this. You can consider anticoagulation, no anticoagulation, and this was an incidental finding, and anticoagulation and no anticoagulation and repeat ultrasound in 1 week time. So it varies from the person to person because the line has been removed, the patient is not symptomatic. So there is no right and wrong in it. It varies from individual to individual. What is your decision? No. Provoked, Sana. It will not. Yeah. It was not spontaneously. But this child is not a leukemia child. This child is not sick. This child is not getting anti-chemotherapy. This child is not sick. Clinically well child. Went for card catheter. Yeah. So it's your choice. So
That's why.
So you can treat. Agree, completely agree. I will recommend that no anticoagulation, repeat and ultrasound in 1 week time if the child is clinically well. So this ASH guideline recommend it's a person to person. There is no right and wrong. Well, you all are right. The panel suggests either using anticoagulation or no anticoagulation in pediatric patient with asymptomatic DVT or PE. Adult data suggests that treatment of most asymptomatic DVT is not required. Challenging to extrapolate to children, giving the difference of anatomy and physiology. Routine, generally it is recommended now. Previously, for every baby who was having the lines, neonates, we were doing the ultrasound. Routine radiological screening for asymptomatic VT should not be done. If detected, decision to treat or not to treat is individualized. Individualized to physician. Natural history and effect of anticoagulation therapy for asymptomatic VT in children is uncertain as per studies. treatment decision should be individualized. What happened? You decide to withhold anticoagulation, given that the burden of the thrombus is small and line has already removed. You monitor her with a repeat ultrasound of the neck in 6 days, and the thrombus that was previously visualized is significantly reduced in size without anticoagulation. She is discharged home from hospital without anticoagulation. 6 months later, after investigation for complex arrhythmia, because this child has something cardiac problem, she undergo a cardiac catheter procedure to ablate an accessory pathway that is assessed by a right femoral vein. The next day, she develops right leg pain and swelling. Now, this is symptomatic. It's very different from previous. Compression ultrasound of the affected nerve reveal an occlusive DVT involving the femoral and popliteal. This also it is provoked because of but here we have got case where it is occlusive one thing and it is symptomatic. Repeat imaging of neck at this time showed total resolution of her initial asymptomatic thrombus. So if you have not treated initially, you were right. Yeah. Now patient has a symptomatic proximal DVT provoked by cardiac catheter in her right leg. When I was working in Jalila Hospital, they were very good in Dubai. There was a very good cardiology unit. So I was facing this every week, 2-3 cases. What management would you recommend for her DVT? No anticoagulation as the procedure is over and she no longer has right to left shunt. Anticoagulation, catheter-directed thrombolysis followed by anticoagulation. Surgical thrombectomy followed by anticoagulation, insertion of prophylactic IVC filter to reduce the risk of PE. Yes, everybody's right. The panel recommends using anticoagulation rather than no anticoagulation in pediatric patient with symptomatic DVT or PE. Panel suggests against using IVC filter, rather use anticoagulation alone in these patients. Majority of the evidence for the treatment of the VT in children is extrapolated from adult. Most VT occur in sick hospitalized children. You have to always discussing when to treat or not to treat. It depends on your child is sick or hospitalized or clinically well. Reserve IVC filter for DVT with absolute contraindication to anticoagulation. Failure of adequate anticoagulation therapy if filter failed to reduce the embolic risk. The panel suggests against using thrombolysis followed by anticoagulation and rather use anticoagulation alone in pediatric patient with DVT. Pooled data with 15 observational studies in children reporting clinical outcome with thrombolysis for DVT, mortality 3.6%, progressive or failure of VTE 22.2%, major bleeding 5.7%, post-thrombotic syndrome 9.5%. Based on these limited data and extrapolation from adult, unlikely that thrombolysis reduces risk of recurrent VTE. The panel suggests using anticoagulation for 3 months or less rather than anticoagulation for longer than 3 months in pediatric patient with provoked DVT or PE. Pediatric data from observational studies say optimal duration of the anticoagulation is unknown. Extrapolation from adult data suggests treating beyond 3 months not needed. However, if provoking risk factor persists because if the child has been sick and has got a line and keep on getting the clots, then you have to consider prophylaxis anticoagulation according to the clinical condition of the patient. You start your patient on therapeutic anticoagulation. Yes. We treated, but in cardiac cases, it provoked a lot because they cause endothelial damage. It's very obvious. Yeah. We usually do agree. Yeah. Nahi aayega. But there is a guideline. It's Ash Generally, after second episode, we prefer to do. Yeah. Which of the following anticoagulation would you suggest? Part 2, agle saal. Which of the following anticoagulation would you suggest as maintenance anticoagulation therapy after first few days of low molecular weight? Any of these, it depend upon the situation, it depend upon the, what is the panel suggest using it, but we have to find it out, what is the clinical situation of the patient, whether the patient go on the low molecular weight heparin, or because with the vitamin, warfarin, you have many interactions, so you have to work on this, the child can take orally or not orally, it all depend. In the absence of robust pediatric specific data, decision regarding low molecular weight compared to VK should consider patient values, preferences, health services, resources, infrastructure and support, underlying condition, comorbidities, and other medication. Yeah, rovarexin has been introduced recently. We are using it, but generally in this case, they have not considered it. This is the ASH case. It's not made. Yeah. Dose, I can check it. I don't have now, but I can check it. Yeah, yeah. I think 50 milligram. Yeah. Yeah. Actually, we are not using much because the rivaroxaban having too many interactions. Voriconazole, ketoconazole, and all those anti-epileptic. But in out of oncology patient, we are using a lot. काफी common use हो रही है oncology में. हमारे available नहीं थी UAE में, recently हमें available हुई है. Add that. Because there is no guideline. I checked on the site, there is no, they are saying new guidelines are underway. It was supposed to be released by the early 2024, but they're still working on it. So maybe new guidelines will leave. And without guidelines, not useful to discuss. The okay, this is done. Yeah, so anyway, the management of asymptomatic VTE should be an individualized decision based on patient-specific risk for recurrent VTE. Thrombolysin and IVC filters should not routinely be used in management of DVT or PE in children. Choice between these, it varies about the family decision. Okay. But in thrombosis, decision should not be in a rush. We recently had a girl, she's an undifferentiated sarcoma of the liver, and we did echo for because she was getting doxorubicin. They found a clot in the right atrium. And immediately the person did call cardiology, and cardiologist came and he said, call surgeon, vascular surgeon, and remove the line immediately. And so these things should not be in a rush. She needs chemo anyway. We treated it anticoagulation. In 3 months, her thrombus has gone very well. Because after all, PE also we treat with anticoagulation. Na? So we did it to the patient, did very well. What's the use of taking this line and putting the second line? What it will add? First of all, this is an oncology child. And so the patient, it slowly goes down, and it did very well. But they write strong recommendation, urgent removal of the line. So these things should be not be rushed. And somebody booked the patient for line removal. So we said, what's the use of removing this line? So especially in oncology children, line is very precious, and we should be not just rushing to remove the lines unless there is definitely a concern. Thank you.
Thank you very much, Dr. Samina, for this interesting talk. And so now it will be a question answer session. So.
I'm Dr. Abdullah. I'm Carlos from Rahman Medical Institute, Peshawar. Thank you very much. They were very good presentations. I enjoyed a lot and learned a lot. I've got a few practical points from Dr. Taj. You talked about the second line chemotherapy in the case of lymphoma, non-Hodgkin. And should it be the second line, gemcitabine, or some other, what they call it, etoposide, ifosfamide? Which one would you prefer this?
Chemotherapy in Hodgkin's disease is really very effective. And there are several regimes that you can use. And over the years, the preferred option has changed in different centers based on availability, on cost, and ease of use, side effects, and so on and so forth. So in some ways, the choice is up to you. So for us, because we use OIPA and COPDAC,
The second line treatment was IGEV because we didn't want to use anthracyclines. But in the past, we've used ABVD and IEP, which was an ifosfamide-based chemotherapy. So in a way, it's up to you which one you choose, depending on availability of drugs. And I know that the adults use a lot of ABVD as first line therapy. So for them, the second line is often GDP, which is gemcitabine based.
And about, what about carboplatin and oxaliplatin?
Oxaliplatin. These are not used because they have quite a
Makes the gemcitabine.
Yes, yes.
oxaliplatin.
I mean, for in pediatrics, they're not used that often because they have a lot of side effects. Oxaliplatin, the neurotoxins, neurotoxicity.
Oxaliplatin and carboplatin, they have got less side effects compared to the others.
Cisplatin, but it's not used that often. But obviously, there are regimes that use them and they are equally effective. For us, we use ifosfamide-based therapies or IGEV, as I said before.
And the second thing is that you told about the targeted therapies.
Yes.
Should it be the first choice or it should be second, third one?
Right. The topic that was given to me was targeted therapies, but over 90% of patients are cured without targeted therapies. So I wouldn't use them as first line. And
they are too
and we
costly
have,
also.
and also they're costly. So these patients, we'd only used it in 22 patients in 10 years. So you can imagine it's not, even now it's not used that often, but because they are available and on the NHS, they don't cost anything to the patient, we tend to use it if patients have had a lot of toxicity before. In my particular case, the girl didn't want to lose her hair. So she wanted to use Pembro because it was an open study and we have to offer them when they are available. And she just told her parents, that's what I wanted. So in different countries, there are different things that are important, but certainly I wouldn't use it as first line because they are expensive, their long-term side effects are unknown, and chemotherapy works equally well.
And then you told about the role of radiotherapy.
Yes.
Well, radiotherapy in the past, because of the complications, the late complications have been stopped. And majority of the centers and majority of the studies, especially in children, you told about should it be restarted or you think it should be a little dose, smaller dose? What's
But
sort
the
of,
history of
excessive-
you, yes, sorry, thank you. The history of use of radiotherapy in Hodgkin's is a very long one. It's very effective. And in the old days, we used to use 35 gray of radiotherapy to the whole sites, to
Yeah.
all the involved sites, including the
We
draining.
have done it also.
Yeah, including the draining
Yeah.
lymph nodes. So the inverted Y for mental.
Mental field, the inverted
Mental-
Y.
Exactly. So those days are gone, but chemotherapy also has a lot of side effects. So what they do, the Euronet protocol does is it uses low dose involved field radiotherapy plus relatively lower dose chemotherapy. The chemotherapy that we use can be given as an outpatient, and it does not affect fertility. The dose of anthracyclines is 160 milligrams per meter square, so the effect on the heart is low. And radiotherapy is only given to those patients who are PET positive. So a huge number of patients are not given radiotherapy. But yes, it's only a small proportion of it. Only
2,000, 3,000.
No, the dose is now 19 gray. Yes, so 2000, close to 2000, 19 gray. And it's only given to involved field. So the fields are much smaller. And then in the latest protocol, what they're going to do is to increase the chemotherapy to DCOPTAC, which is a bit more intensive, and only give radiotherapy to those patients who are late PET positive. You know, you do a PET scan at the end of treatment, and after this more intensive chemotherapy, if the PET is still positive, they get it then. So the proportion of patients who get radiotherapy is getting less and less. And even the ones who get it,
get more involved field. So it's almost like a postage stamp rather than involved field and all the draining lymph nodes. So-
What they used to call it, the iceberg therapy.
Okay.
Where the iceberg is there.
Or the
with a
top.
Huge lymph node mass, so they used to give it to this.
Hmm. So I mean, it is getting less toxic. And because I do late effects as well, I really don't, I mean, obviously they need follow-up echoes because they get 160 milligrams per meter square of anthracyclines, but their long-term side effects are much less than they used to be. And with these, I mean, the reason why these targeted therapies are coming is because they want to reduce the burden of late effects even lower, even lower than that. And because hair loss for a teenage girl is huge. So I think that's one big plus for targeted therapy.
Okay, thank you very much.
Thank you.
Any other questions, please?
Ikram Haq, Doha, Qatar. I have a sort of a comment for Samina here. The problem we face, and I have to defend it because I do recognize you, I can call you guys, and thank you for being available to, with these hard decisions, I would say. The problem what we find when we are applying these guidelines, ASH or others, is the level of evidence we have. As you can see, all of these evidences have a very low certainty, not even low certainty, very low certainty. And all of these recommendations are based on conditional recommendations, which basically are experts' opinions, right? And so we often find once in a while, so you have an intellectual discussion or MBT type meeting, and then we go to the parents and say that this is what we are going to do. We do tell them that there is a problem. So parents, as you know, with the cardiac surgeries, right, you have a little IV worm over here. So then the next day you go and you are examining where there is this incision, chest tubes coming out, everything. And then the mother asks me, well, what is this? Like this. So they get focused on these things. And what the challenge we face is how we discuss these things with them when the evidence is low certainty. And I heard this a lot where people say, well, you wait for the new guidelines. The issue in my mind, and I think where we need to progress is not waiting for new guidelines, but to generate more evidence so that we can have better guidelines to recommend us. Because we often find these patients where there was this thrombus, we left it alone based on the intellectual discussion, and 2 months back, the patient came back, and now I have to put a central line and that vessel already had a thrombus. And so that becomes like a problem.
It's a visualize, or sit the time, what we're expecting in the future. Absolutely, we all do this stuff.
Yes.
Because it varies a lot, especially with PIC. That's what I'm saying. Sometimes they call the lines in the movement and for. Better to sit down and discuss before the line.
No, I agree with you 100% on that. I rather would not put another line and wake up at night time to do that, but just, for that, I think.
Not the guideline is just guideline, but experience along with the guideline.
Okay, yes. So my point here for the younger generation and some of the ICU folks are, please consider that it is individualized based. The evidence is extremely low certainty evidence. And so when you make a decision, you have to go that perspective.
I have a question for Dr. Selina. So my first question, I would like to know on your thoughts about the management of tumor-related thrombosis. So, for example, in male tumor, even if there is a big thrombus going through the vein, I can see when we have seen the patient coming with advanced disease, that thrombus is going into right atrium, we don't give any coagulation to the tumor. So apart from this, for the rest of the tumors, like we see patients in our practice that the patient comes for staging scan, and we found out that there is a tumor thrombus is actually extension of tumor into a vessel, but otherwise patient is asymptomatic. So what should be the approach of what should be?
I would refer if the patient is symptomatic and your blood forms and veins level to give better. I prefer to do it because why do this thing in a symptomatic patient, especially if you are going to visit the cancer child, you're putting in the central line, you're expecting in a child, that child is going to be bedridden for a long time. With all these things, I would prefer if it is the same patient. Even in a asymptomatic. It takes a huge plot, like, oncology prefer to be asymptomatic. Because they are mostly bedridden, sometimes they get dehydrated. There's so many factors that we get that we usually treat. So this is like the two diagnosis that sometimes we have like especially on tumor lymphoma, where you have limited silent tumors and they go into the device, right? And sometimes you have these huge germ cell tumors which sort of penetrate into your brain, right? So I think sometimes the explanation to and fro is that just because immune system you do not give them anything, the chemotherapy gets to be reduced. So it's something very difficult even if the radiologist to say whether this is a bland or a tumor. That is why you can have this. Right. But sometimes I feel if the patient is sick, this patient is going to be very for a long time. You are going to see them the chemotherapy, preferable, the blood count. Yeah, you know, therapeutic media. You're taking the anti-oxidant. Because for us it is not available. So I was very scared of integrating the patient initially, it was not available. So I was very scared of integrating the patient without knowing the patient. Depending how you are supposed to help me, I did that. We are trained to do it without the technical because we are
So yeah, because also not available, but not available, very expensive. Like so, can check it almost twice, but we can't do that. And the second question is if a patient is on anticoagulation therapy, and if you find out that there's a strong family history of thrombotic events, then what should be the approach to check thrombotic screen when a patient is already on anticoagulation therapy? How we should approach for you should still check just the same thing.
basic workup we do a lot. Protein, as a forming, 4-5 things we do. When you look at it. So it's very important.
Yeah, that's very important. Yeah, let's say just we can't stop this again.
It's just that long. It takes few weeks to pass. It is to decide. In one sugar, we don't have to be one that you get no with the water stream, you need to check levels to be I have to consider that. What is unfortunately, the person is not. Then we have the first we do after 1 week. Yeah, because maintaining the same then after 2 hours. 4 hours after 4 hours. Then it can't be the
इसने कंप्यूटिंग तो नहीं करना नहीं from the organizers.
So, I was in the training monitor of this very so afterwards I was getting someone you were a small very good more very good because that's my daughter is that even opposite was so far but then even what I
I think there is no straightforward answer what we're using for the tumor thrombosis of use low molecular weight heparin in tumor thrombosis, because in our setup, it is even more challenging. Why? Because, you know, their platelets are less than 50 most of the time, and it's not easy to arrange platelets in our setup. So even if we want to start, it's not easy because after when they get chemo, then the platelet count drops, and then yes, in the leukemia, it's a separate problem. Yeah. Individualized. I think it's individualized, as we said, like experience plus the guidelines. So it's a combination of those. Yeah.
Right.
Yeah.
This is telling us, but if if the guidelines only is followed, then we need not to have our knowledge and experience. Guidelines are just guidelines that are kind of
I have some questions. So for brentuximab, we do have it available through an access program, patient access program. But it takes about, a month, like 4 to 6 weeks for the first dose to arrive, and then you have to apply. So during that time, what's your recommendation? So what we've been doing is giving a dose of bendamustine in between as monotherapy, just so that the tumor doesn't progress. Is that a good idea to use that as monotherapy, or should we just bring the steroids while you're waiting for the brentuximab? I'm talking about refractory patients who usually that's their time therapy. And fourth line. Yeah. Yeah, so that is, so what bridging do we get it? That was my question. Something like that, just to keep the asymptomatic. My second line. We using brentuximab as fourth line right now, bendamustine.
So we have been given this second drop as a third line chemotherapy, and it is generally very well tolerated in at least pediatric patients up to 8 minutes or 90.
We use Epic, which is ifosfamide, prednisone, and then prophylactic My second question was the brentuximab maintenance. How long would you keep kids on maintenance with brentuximab?
I think can be given after year, but depends on how that's it. But it's very good. After that.
So I just asked the specific patient that I have, there's someone who was unable to harvest after 3 attempts. So she had primary refractory, went into depression with bendamustine, brentuximab, but we could not get her to transplant. So I used radiation to consolidate. And now I have like 3 or 4 doses of brentuximab left for her. So I'm just going to give those because I have them. But should I request for more?
What do you have?
She's quite negative before radiation. Thank you.
So Dr. Mehta, do not give up. There are 2 people in the department. You are not giving up.
Any more questions? Thank you all of you for coming, and I hope you enjoyed today and had a great day. So I hope see you all tomorrow for our pediatric palliative care session. So please join us tomorrow. Thank you very
It'll
much.
be at 9 o'clock tomorrow morning. जो रोटा में वो मैंने schedule share किया था, it's 8:30. It's not actually 8:30. It's 9 o'clock, and it's going to be Shalimar Hall C. And I think it's the first time we are having a pediatric palliative care session in the Shaukat Khanum Symposium tomorrow. So I will see you tomorrow morning, and some of you we will see you in the dinner tonight. Thank you.